Welcome. This is Dr. Raju Devde, Professor in Pharmacology, Kaktiya Medical College, Warangal. I'm repeating this lecture. I'll be starting with antiretroviral drugs, as the previous lecture had some audio issues. So I will start with the antiretroviral drugs and the drug targets. As we have discussed in the previous lecture, that there are 4 categories of antiretroviral drugs available. Number 1, NRTIs, that is nucleoside and nucleotide reverse transcriptase inhibitors. Number 2, non-nucleotide reverse transcriptase inhibitors. Number 3, protease inhibitors. Number 4, the entry inhibitors. Number 5, fusion inhibitors. Number 6, integrase inhibitors. So we have looked into the life cycle of antiretroviral drugs and its drug targets. So NRTIs and NNRTIs, they are abacavir, didanosine, emtricitabine, lamivudine, stavudine, tenofovir, jalcitabine, and zidovudine. The zidovudine is also called as azithromycin, which is the first drug which was used for the treatment of HIV and AIDS. Out of these NRTIs, that is all these are nucleoside reverse transcriptase inhibitors except tenofovir, which is a nucleotide reverse transcriptase inhibitor. And apart from these, we have NNRTIs, that is non-nucleoside reverse transcriptase inhibitors. They are first generation and second generation drugs. First generation NNRTIs are delaviridine, efavirenz, and nevirapine. And the second generation are etravirin or rilpivirine. So these are second generation. So these 2 categories of drugs, like NRTIs and NNRTIs, they act by inhibiting the enzyme reverse transcriptase. Okay. Then we have another category of drugs which are called as protease inhibitors. These protease inhibitors, they act or they block the protease enzyme, and they inhibit the maturation, and they inhibit the budding and maturation. They are effective on the late phase or the late viral cycle or late retroviral cycle where the budding and maturation takes place. So these are the protease inhibitors. These protease inhibitors, they have a lot of adverse drug reactions. Also these NRTIs and NNRTIs, they are having a lot of ADRs, especially the NRTIs. And the protease inhibitors are atazanavir, darunavir, fosamarinavir, indinavir, ritonavir, lopinavir, nelfinavir, and saquinavir. So all these drugs which have vir, they are the protease inhibitors. This is the third category of drugs. Then the fourth category of drugs are the entry inhibitors. So these entry inhibitors, they mainly act by blocking the chemokine coreceptors. They are called as chemokine coreceptor antagonists. Like the drug available is maraviroc. Then we have the fifth category of drugs, which are the fusion inhibitors. So these fusion inhibitors, they block the fusion of, these fusion inhibitors, they block the drug which blocks this fusion inhibitors is enfuvirtide. So enfuvirtide is a drug which acts by blocking the CD4 cell receptor. Okay, and the drug available is enfuvirtide. Then lastly, we have this integrase inhibitors. So this integrase inhibitors, they act by blocking the integrase enzyme, which causes the integration, which acts by inhibiting the integration of the viral DNA, double-stranded viral DNA into the host human DNA. So these are the 4 6 category of drugs which are available for the treatment of HIV and AIDS. Now, when you look into the principles of antiretroviral therapy, this antiretroviral therapy is also called as HAART. HAART is nothing but highly active antiretroviral therapy. And this is defined as a regimen consisting of 2 NRTIs and 1 protease inhibitor, or a NNRTI. So, HAART regimen, one regimen in the heart constitutes 2 NRTIs, that is 2 nucleoside reverse transcriptase inhibitors plus a protease inhibitor, or a non-nucleoside reverse transcriptase inhibitor. The second regimen is we can also combine 2 protease inhibitors and 1 other antiretroviral agent. So this is the HAART regime, that is highly active antiretroviral therapy. So what are the principles of these HAART regimen or antiretroviral therapy? When you look into the principles, the principles are maximal and durable suppression of viral load. Any antiretroviral regimen or HAART regimen should result in maximum and durable suppression of the viral load. Not only that, secondly, it should restore and preserve the immunological function of the individual. Thirdly, there should be a reduction of HIV-related morbidity and mortality. Number 4, there should be improvement of the quality of life of HIV-infected persons. Number 5, the prevention of mother-to-child transmission, which is called as PMTCT. Then number 6, it should be useful in post-exposure prophylaxis as well as pre-exposure prophylaxis, which is a classical example of pre-exposure prophylaxis is discordant couple. So what does this discordant couple related with pre-exposure prophylaxis mean? That means to say one of the spouse in that particular couple is having HIV positive. The other spouse is HIV negative, but still both the partners have to be initiated on antiretroviral therapy and HAART regime. So that is what is called as discordant couples who are being treated with pre-exposure prophylaxis. Now we will go into detail regarding the various drugs, the antiretroviral drugs. The first category of drugs are nucleoside and nucleotide reverse transcriptase inhibitors like NRTIs and NTRIs. Okay, nucleoside and nucleotide reverse transcriptase inhibitors. So all the drugs in this category are nucleoside reverse transcriptase inhibitors except tenofovir. Tenofovir is a nucleotide reverse transcriptase inhibitors, whereas abacavir, didanosine, emtricitabine, lamivudine, stavudine, zidovudine, zalcitabine, all are nucleoside reverse transcriptase inhibitors. So these drugs, NRTIs and NTRIs, were the first agents available for the treatment of HIV infection. But when these drugs are compared to that of NNRTIs and protease inhibitors, they are less potent. But they have a very important and central role to play in the treatment of HIV and AIDS. They also have an activity against both HIV-1 and HIV-2 infection. They are the analogs and derivatives of nucleoside and nucleotides. These NRTIs and NTRIs, they mainly differ from normal substrates only by a minor modification in the sugar moiety, that is the ribose molecule. Now, when you look into the mechanism of action of these NRTIs or NTRIs, they act mainly by interrupting the HIV replication cycle via competitive inhibition of HIV reverse transcriptase enzyme, and they result in termination of the DNA chain. So they act by interrupting the HIV replication cycle via the competitive inhibition of HIV reverse transcriptase, and they terminate the DNA chain. What are the functions of these reverse transcriptase? So reverse transcriptase is an HIV specific DNA polymerase, that is RNA dependent DNA polymerase, or HIVs, because HIV contains RNA. So it is also called as RNA dependent specific DNA polymerase. So this reverse transcriptase, it mainly allows the HIV RNA to be transcribed into a single stranded and ultimately into double-stranded proviral DNA, which is then incorporated into the host cell genome. So this reverse transcriptase allows the RNA to be transcribed into single-stranded and ultimately into double-stranded proviral DNA, which then gets incorporated into the host cell genome. So this proviral DNA chain elongation is very much required before the genome gets incorporated into the host cell genome. And they mainly are the acting as false building blocks, which causes the chain termination. So these are the various functions of the reverse transcriptase enzyme. So when you look into the mechanism of action of reverse transcriptase enzyme, this is a CD4 cell, that is the host cell, and their transcription process is occurring at this level. So this reverse transcriptase enzyme is inhibited by NRTIs and ANTI-RETROVIRAL. So this is where the NRTIs and ANTI-RETROVIRALs, they are going to act by inhibiting the enzyme reverse transcriptase. Now, when you look into the pharmacokinetics of NRTIs, these are actually the prodrugs, and they undergo phosphorylation by the intracellular kinases, and they result in their activity, or they exert their activity by phosphorylation of the intracellular kinases. And looking into the bioavailability or the oral bioavailability of these drugs, it ranges from 25% to 93%, where tenofovir and didanosine are having the lowest oral bioavailability when compared to that of the other NRTIs. Okay, tenofovir is a nucleotide reverse transcriptase inhibitor. It is a nucleoside reverse transcriptase inhibitor, didanosine. So these two drugs in this particular category have less bioavailability. Not only that, food does not significantly affect the absorption of these drugs except didanosine, which must be taken on an empty stomach. Okay, so didanosine has to be taken on an empty stomach. Then all these drugs are eliminated through the kidneys. And the exception is that of abacavir, which can be given in normal doses regardless of the creatinine clearance. That means to say, even if there is some form of renal impairment, abacavir can be given in normal doses, whereas other drugs, they have to be either stopped or the doses have to be reduced to 50%. And these drugs, NRTIs, they have a minimal drug-to-drug interactions, but the clinical significant interactions involved with didanosine. When didanosine is given with tenofovir, the levels of it are higher. So tenofovir and didanosine are combined. The tenofovir will cause an increased levels of the didanosine, and didanosine and ribavirin combination should not be given or should be avoided. They are contraindicated. Didanosine and ribavirin are never used in a combination. Now, we look into the individual drugs. Here, the individual drugs are dealt with in the name, the dosage, adult dosage, and adverse effects. So now, what I will going to do is, I will not be discussing about the dosage and adult dosage because the slides will be already there in the presentation. So we would look into the adverse drug events of the various drugs, that is the NRTIs. Firstly, abacavir. Abacavir, it mainly presents with hypersensitivity reactions. And not only that, the hypersensitivity reactions with abacavir is very, very high risk of developing hypersensitivity if the patient is positive for HLA-B infection. So before starting abacavir, one has to perform HLA screening before initiating abacavir to prevent the hypersensitivity reaction, which is of serious in nature if the person is having HLA-B positivity. Now coming to didanosine. Didanosine, it mainly presents with pancreatitis, peripheral neuropathy, and lactic acidosis. So lactic acidosis, pancreatitis, peripheral neuropathy, nausea and vomiting, they are the major side effects of didanosine. Then we look into emtricitabine. It has a very minimal toxicity with hyperpigmentation, the only one which is present with emtricitabine. Then coming to lamivudine. Lamivudine also has minimal side effects, but sometimes there are severe acute exacerbations of hepatitis which may occur when there's a concomitant hepatitis B viral infection. So lamivudine, when it is given for the treatment of HIV and the person also has hepatitis B virus co-infection, there is exacerbation of hepatitis or liver toxicity. Apart from that, stavudine, it presents with development of peripheral neuropathy, pancreatitis, lactic acidosis, lipoatrophy, and hyperlipidemia. Similarly, tenofovir, which is a nucleotide reverse transcriptase inhibitor, causes GI side effects, headache, asthenia, and renal insufficiency. Then judovidine, as I told you, it is the first and foremost drug introduced in an NRTI for the treatment of HIV. It causes anemia, granulocytopenia, myopathy, lactic acidosis, hepatomegaly, steatosis, nail pigmentation, lipid abnormalities, lipoatrophy, and hyperglycemia. So if you look at the adverse drug reaction profile of NRTI, a more serious adverse drug reaction profile with NRTIs are seen, especially looking at the hypersensitivity reaction associated with the HLA-B positivity, or the hepatitis associated with hepatitis B virus co-infection. Then we have endocrinological adverse drug reactions, and then the pancreatitis and lactic acidosis, asthenia, and renal failure. All these are the major adverse drug reactions with the nucleotide and nucleoside reverse transcriptase inhibitors. Now we'll go to the second category, that is NNRTIs, that is non-nucleoside reverse transcriptase inhibitors. So these NNRTIs were introduced in the year 1996 with the approval of nevirapine, and these drugs are having a high potency of activity against HIV-1 and are a part of preferred initial regimens. So NNRTIs are the preferred initial regimens because they mainly are highly potent against the HIV-1 virus, and efavirenz among all of them can confer the most significant inhibition of viral infectivity. So it is highly potent among all the drugs. And apart from that, all these NNRTIs exhibit the same mechanism of action by inhibiting the enzyme reverse transcriptase. So the transcription of viral DNA into, the transcription of viral RNA to a double-stranded viral DNA has been inhibited by this particular group of drugs. Now, when you look into the drugs, the first generation NNRTIs are delavirdine, efavirenz, and nevirapine. So the second generation drugs are etravirin and rilpivirine. Then the mechanism of action of NNRTIs. HIV reverse transcriptase, it is a heterodimer composed of two subunits, that is P66 and P51. So HIV reverse transcriptase is an heterodimer composed of two subunits, P66 and P51. And this NNRTIs bind to the P66 subunit at a hydrophobic pocket, which is distant from the active site of the enzyme, which is the allosteric site. And this non-competitive binding induces a conformational change in the enzyme. Now, when you look into the first generation NNRTIs, they are more rigid in structure, and there's a likely development of resistance. There's a quick development of resistance which can occur. And when you look into the second generation NNRTIs, which have a more flexible structure and they can adjust readily and resist mutations, mutation, and they are very highly effective drugs. Now, the resistance to antiretroviral drugs, maybe say NRTIs or NNRTIs, mainly occur at the level of conversion of the single-stranded RNA into the double-stranded DNA, where majority of the mutations take place. And whenever there is a development of mutations, the conversion of single-stranded RNA, HIV RNA to the double-stranded HIV DNA. Okay, so single-stranded RNA to double-stranded HIV DNA. This is the area where a lot of mutations are formed, which will result in development of the drug resistance to antiretroviral drugs. Now, the mechanism of action of NNRTIs, again, the NNRTIs also act by inhibiting the enzyme reverse transcriptase. Now, what are the pharmacokinetics of NNRTIs? All the NNRTIs utilize the cytochrome P450 for metabolism, and they either exert a varying degree of induction, enzyme induction, or enzyme inhibition effects on the specific isoenzymes, especially cytochrome 3A4 and cytochrome 2C9. And this results in a significant potential for drug-to-drug interactions. When you look into delaviridine primarily, which uses cytochrome 3A4 isoenzyme for metabolism, nevirapine is metabolized mainly by CYP3A4 with some secondary metabolism which also occurs through CYP2B6. And when efavirenz is primarily metabolized through 2B6 and secondary through CYP3A4. Etravirin is a substrate of 3A4, 2C9 and 2C19. So all these NNRTIs, as I told you, that they utilize the cytochrome P450 for the metabolism, and they exert varying degrees of enzyme induction and inhibition effects on the specific cytochrome P450 isoenzymes. These drugs, they are highly plasma protein bound, around 98 to 99% plasma protein bound, primarily to the albumin and alpha-1 acid glycoprotein except nevirapine. And the serum plasma half-lives are very high, which ranges from 25 hours to 55 hours, with an exception that delaviridine, the plasma half-life is 2 to 11 hours. Now, when we look into the individual drugs, delaviridine, it is having the adverse drug reaction profile of rash and headache. Efavirenz has an adverse drug reaction profile of rash and CNS side effects like somnolence, vivid dreams, confusion, visual hallucination, and hyperlipidemia. Etravirin has a side effect like rash and nausea. Nevirapine has rash and hepatitis. Relpivirine, they have depressive disorders, insomnia, headache, and rash. So when compared to that of the NRTIs, NNRTIs have a very less incidence of adverse drug reactions with a minimal incidence of ADRs. That is the reason why in the main regimen of especially the antiretroviral therapy or HAART, we use 2 NNRTIs or 2 NRTIs and 1 NNRTI like that. So that is the reason. So these group of drugs, they really have very less adverse drug reaction profile. Then we go to the third category of drugs. They are the protease inhibitors. So these protease inhibitors were introduced in 1995, even before the NNRTIs. And they are an integral part of the treatment. Protease inhibitors will be an integral part of the heart regimen, and they mainly exhibit the activity against the both HIV-1 and HIV-2 infections. So what are the drugs which are available as protease inhibitors? Like atazanavir, darunavir, fosfamprinavir, indinavir, lopinavir or ritonavir, nelfinavir, saquinavir, and typrinavir. So these are the drugs, that is the protease inhibitors, which are going to act in the replication, the late replication stage of the retrovirus. Now, we will look into the mechanism of action of these protease inhibitors. The HIV protease enzyme is a 99 amino acid aspartic acid protein responsible for maturation of virus particles late in the viral life cycle. Okay, so HIV protease enzyme is a 99 amino acid aspartic acid protein responsible for maturation of the virus particles late in the viral life cycle, and they systematically cleave the individual proteins from GAG and GAG-POL polypeptide precursors into the functional subunits for viral capsid formation during or shortly after viral budding from an infected cell. So these protease inhibitors are the competitive inhibitors of the enzyme protease, and they directly bind to the HIV protease enzyme and prevent subsequent cleavage of the polypeptides. So hence, the mechanism of action of polypeptide or protease inhibitors is in the late stage of viral replication, the retroviral replication, the late stage where the budding of the viruses takes place. It's going to act at that particular level, the protease inhibitors. Now coming to the pharmacokinetics of protease inhibitors, they are having a significant first pass metabolism by cytochrome P450, 3A4 and 3A5, and also they have intestinal efflux by P glycoproteins. So that means to say there is a significant first pass metabolism, as well as there's an glycoprotein or P glycoprotein, PGP, P glycoprotein, which is an efflux protein present in the intestinal mucosa, and hence the bioavailability of these drugs is very much reduced because of the first pass metabolism and intestinal efflux by P glycoprotein. But when you look into the plasma protein binding, it is very high, and primarily they bind to albumin and alpha-1 acid glycoprotein except indinavir. It does not bind with the alpha-1 glycoprotein, acid glycoprotein. So they are having very short plasma half-life ranging from 1.5 to 2 hours for indinavir and 7 hours for atazanavir. And they are having significant drug interactions with medications cleared through the cytochrome P450 isoenzyme. So they have a lot of drug-to-drug interactions because they are metabolized by CYP, 3A4 and 3A5. And the low dose ritonavir, like 100 to 200 mg, is frequently co-administered with other protease inhibitors to block the intestinal and hepatic cytochrome 3A4 metabolism. That means to say, when we combine or give a low dose of ritonavir with other protease inhibitors, which is going to block the intestinal as well as the hepatic CYP3A4 metabolism. Now, we will look at the individual drugs. Atazanavir, they cause indirect hyperbilirubinemia. They result in prolonged PR interval, hyperglycemia, skin rashes, and hyperlipidemia. Darunavir also causes hyperlipidemia and hyperglycemia and the skin manifestations. Fosfamprinavir also results in skin manifestations, GI disturbances, hyperlipidemia, and hyperglycemia. Indinavir also causes nephrolithiasis, nausea, vomiting, indirect hyperbilirubinemia, hyperlipidemia, and hyperglycemia. Likewise, if you look at the other drugs like lopinavir and ritonavir, they also cause GI disturbances, hyperlipidemia, hyperglycemia. Nelfinavir also causes hyperlipidemia, hyperglycemia. Ritonavir also causes hyperlipidemia, oral paresthesia, asthenia. Saquinavir causes the QT prolongation and PR interval prolongation. So here we have a drug which is called as atazanavir, which causes PR interval prolongation. Then we have another drug which is called as saquinavir, which causes PR interval and QT interval prolongation. Then we have tiprenavir. It causes hepatotoxicity, hyperlipidemia, hyperglycemia, and intracranial hemorrhage. So when you look into these protease inhibitors, so these protease inhibitors, they have significant adverse drug reaction profile, like endocrinological adverse drug reaction profile, the GI disturbances, they have the cardiac manifestations, they have liver manifestations, and so on and so forth. The protease inhibitors are the drugs which have lot of endocrinological disturbances and hyperlipidemia, oral paresthesias. They also have intracranial hemorrhage, especially with tiprenavir. Then when we look into the fourth category of drugs, they are called as entry inhibitors, or they are also called as chemokine co-receptor antagonists. We have maraviroc. So maraviroc is a drug which is available in the category entry inhibitors. So this maraviroc, it acts by binding of GP120 HIV surface protein to the CD4 cell receptor, which induces a structural change that reveals the V3 loop of the protein. This V3 loop then binds with the chemokine co-receptor and allowing the GP41 to insert itself into the host cell and leading to the fusion of the cell membranes. So here, this entry inhibitors, they are maraviroc. They act by binding to the GP120 HIV surface protein to the CD4 receptor and induces a structural change that reveals V3 loop of the protein. Similarly, this maraviroc selectively and reversibly binds to CCR5 chemokine co-receptor, blocking the V3 loop interaction and inhibiting the fusion of the cellular membranes. At the same time, as some viral strains may use an alternative chemokine co-receptor CXCR4 for the entry. So to differentiate between the utility of CCR5 for the entry or CXCR4, a tropism assay is necessary to confirm that the patient's virus only uses the CCR5 for the entry of the virus into the host cell. Now, if you look at this particular slide, it is going to show you how the HIV virus that is containing the RNA, single-stranded RNA, with the GP41 and GP120 binding to the CD4 cell receptor. After binding to the CD4 cell receptor, the CD4 cell binding and chemokine co-receptor binding, the virus and cell fusion occurs. So you can see here, GP41, GP120, it binds with the V3 loop, and then it combines with the CD4 cell, and also it involves the fusion of CCR5 or CXCR4 receptor to the host cell. This is how there's an entry. Then when you look into the pharmacokinetics of these entry receptors, so we have 75% of this maraviroc is plasma protein bound, primarily to the albumin and alpha-1 acid glycoprotein. The terminal or the termination half-life is 15 to 30 hours, and it is metabolized through cytochrome 3A4 and is also a substrate of the P-glycoprotein, which is the efflux protein. The dosage adjustment is required when administered in combination with potent inhibitors or inducers of cytochrome 3A4. For example, if this particular maraviroc is administered with enzyme inducers, the dose has to be, when it is administered with inducers or inhibitors, when it is administered with inhibitors, the dose has to be reduced. So maraviroc, when it is administered with cytochrome 3A4 inhibitors, the dose is reduced 150 milligrams orally BID. when it is administered with enzyme inducers, because it metabolizes the Meroviroc very rapidly. So the high dose is given, that is 600 mg orally BID. When we look into the adverse drug reaction profile of Meroviroc, it presents with constipation, dizziness, cough, pyrexia, upper respiratory tract infections, the musculoskeletal symptoms, hepatotoxicity, and nasopharyngitis, which are the typical adverse drug reactions of Meroviroc. Now, we will look into the next category of drugs. They are the fusion inhibitors. The fusion inhibitors, the classical example is enfivirtide. They mainly act extracellularly to prevent fusion of HIV to CD4 or other target cell. They block the second step in the fusion pathway by binding to HR1 region of GP41, that is glycoprotein 41, which is the glycoprotein, the envelope protein, that is GP41. And it does not allow HR1 and HR2 to fold properly. Thus, it causes preventing the conformational change of a glycoprotein 41, which is required for the complete final step in the fusion process. So this is how the fusion inhibitors are going to act, that is the enfivirtide. The dose of this particular enfivirtide, it is given subcutaneously 90 milligrams twice a day. And the dose adjustments are not required in patients with renal failure as well as with mild to moderate hepatic insufficiency. There is no need for dosage adjustments both in renal insufficiency and mild to moderate hepatic insufficiency. When you look into the adverse drug reaction profile of enfivirtide fusion inhibitors, especially there is pain at the injection site, erythema, induration, and nodule formation, diarrhea, nausea, fatigability, hypersensitivity reactions, and increased chances of bacterial pneumonia are also reported with enfivirtide, which is a fusion inhibitor. Now, if you look at this slide mainly depicts the various replicating stages of the retrovirus. For example, right from the anionic polymers, where the virus attachment occurs to the host cell, followed by the virus entry, which is blocked by the CD4 inhibitors or the chemokine receptor inhibitors like enfivirtide. Later on, after the virus has entered, the reverse transcription occurs, and this reverse transcription is inhibited by NRTIs and NNRTIs, then followed by integration of the viral DNA into the host cell genome, which is inhibited by the entry or integrase inhibitors. This results in transcription and translation of the viral particles and synthesis of proteins, and the proteolytic process of the viral proteins formation and assembly is been inhibited by the protease inhibitors. Later on, there is budding and new virus particles. When this particular stage is inhibited, the budding of the virus or the new virus particle formation is also getting inhibited. So this one slide, it will depict the various replicating stages of the virus, the retrovirus, and the various drugs which are going to act at various stages in the replication of the retrovirus. Now, we will look into the last category of drugs, which are called as integrase inhibitors. These integrase inhibitors are also called as HIV integrase strand transfer inhibitors. HIV integrase strand transfer inhibitors, they are also called as INSTI. So this HIV integrase, what does it do? The integrase which is present in the HIV integrase enzyme is responsible for the transport and attachment of proviral DNA to the host cell chromosomes, allowing the transcription of viral proteins and subsequently assembly of the viral particles. Hence, the proviral integration involves two catalytic reactions. Number one, it causes processing in the host cell cytoplasm to prepare the proviral strands for attachment. Secondly, the strand transfer, whereby proviral DNA is covalently linked to the cellular DNA. So these integrase inhibitors, they competitively inhibit the strand transfer reaction by binding to the metallic ions in the active site. So what are the drugs which are available as integrase inhibitors? They are raltegravir, elvitegravir, and dolutegravir. So this dolutegravir is the newest integrase inhibitor, and it is given as once a day preparation and can be taken separately even without combining with other drugs. So this does not require a booster dose. So dolutegravir is the latest integrase inhibitor, which is the newest one, given as once a day preparation, can be taken separately. And this particular drug works against the virus that is resistant to raltegravir or LVtegravir. That means to say the drugs like raltegravir and LVtegravir resistant HIV infections can be treated with dolutegravir. Now, what the pharmacokinetics of integrase inhibitors? When you look into the pharmacokinetics of raltegravir, it has rapid absorption and can be taken with or without food, and it has a plasma half-life of 10 to 12 hours. The longest plasma half-life are seen in women. Okay, and 83% of this particular raltegravir is plasma protein bound, and this particular drug raltegravir is metabolized by UGT enzyme, that is uridine diphosphate glucuronidase transferase, and other antiretroviral agents may alter the metabolism of this raltegravir. And raltegravir never has to be combined with antacids, because antacids decrease the absorption of raltegravir. So antacids may decrease the absorption by divalent cation binding. Hence, raltegravir should never be combined with antacids. Now, coming to the LVtegravir, it is administered with low dose ritonavir, that is 100 milligrams, to reduce its first part metabolism and systemic clearance. So when we administer low dose ritonavir, it will reduce the first pass metabolism and systemic clearance of LVtegravir. So co-administration results in 20-fold increase in the systemic exposure and a terminal half-life for 10 to 13 hours. This particular drug is also metabolized through cytochrome 3A4, which happens to be the substrate of statins, that is HMG-CoA reductase inhibitors. So statins are contraindicated when we give LVtegravir in combination, because statins follow the same substrate CYP3A4, so they should not be given when LVtegravir is given. And they are metabolized through CYP3A4 as well as UGT1A1 and UGT1A3, that is uridine diphosphate glucuronidase transferase 1A1 and uridine phosphate glucuronidase transferase 1A3. And the drug-to-drug interactions with other medications are likely to happen because of ritonavir, and antacids may decrease the absorption of LVtegravir. Now, when you look into the drug reaction profile or ADR profile of raltegravir, it causes GI side effects, headache, and there's elevation of creatinine kinase enzyme resulting in myopathy or rhabdomyolysis, which is very rare. So raltegravir, there is myopathy, headache, nausea, diarrhea, and rhabdomyolysis, which is very rare. Then when we look into LVtegravir, it is presents with nausea, diarrhea, fatigability, and headache. So this is available as a quad pill, LVtegravir plus cobistatin is a combined pill. That's the thing. Now, when I talked about this dolutegravir, which is the newest drug, that is the newest integrase inhibitor, which is highly effective in patients who are resistant to raltegravir or LVtegravir. Then we have a new drug available, or which is in pipeline, that is called as a maturation inhibitor, which is going to act in the late cycle replication cycle of the retrovirus, that is beverimat. So beverimat is the latest drug which is in pipeline, called as maturation inhibitor. Then there are various commercial fixed dose combinations available, like zidovudine and lamivudine. These are two NRTIs. Zidovudine and abacavir, two NRTIs. Zidovudine, lamivudine, and abacavir, they are again NRTIs. Tenofovir and emtricitabine, they are NRTIs. Tenofovir, emtricitabine, and efavirenz, NRTI and NNRTI. Stavudine, lavivudine, and nevirapine, these are NRTIs, two NRTIs and one NNRTI. Lopinavir and ritonavir, these are protease inhibitors. Like that, we have various combinations available. These are the commercial fixed dose combinations used in the antiretroviral therapy or HAART regime. Then, when you look into the potential drug interactions with protease inhibitors and nucleotide and non-nucleotide reverse transcriptase inhibitors, protease inhibitors and NNRTIs, non-nucleotide reverse transcriptase inhibitors. So whenever we are using this protease inhibitors and non-nucleotide reverse transcriptase inhibitors, the statins like simvastatin and lovastatin have to be used carefully, or they cause a lot of side effects. They are contraindicated. Azole group of antibiotics, because they are the enzyme inhibitors. Anticonvulsants, they are actually the inducers of enzyme. Antituberculous drugs like rifampicin is an enzyme inducer. Warfarin induces the metabolism. Midazolam, triazolam, clarithromycin is an enzyme inhibitor. Oral contraceptive pills, the metabolism is induced. Amitriptyline. So all these drugs, they have having potential drug interactions with protease inhibitors and non-nucleotide reverse transcriptase inhibitors. Then the major antiretroviral agents which are under clinical trials, we have NRTIs. The drug which is under clinical trial is elvucitabine. Elvucitabine is the nucleotide reverse transcriptase inhibitor. Then another drug is IDX 899 and TMC 278. The protease inhibitors which are in pipeline are brecanavir. Brecanavir is a drug which is under a clinical trial. We have an entry inhibitor. Those are under clinical trials like becriviroc. Becriviroc. We have maraviroc available. Now this is becriviroc that is under clinical trial, and Pro 140. The fusion inhibitors like T1249, interleukins 2, and there's a lot of research and activity which is happening with respect to vaccine development like VCP1452, GP160. Then we have this integrase inhibitors like elbitagravir. Hydroxyurea compounds also, they are being tried and they are under clinical trials, and they are in pipeline like BCX34. And we do have new drug classes like maturation inhibitors, that is bevirimat, that is under pipeline, and this probably may have a good effect, is mainly acting at the level of the maturation of the budding viruses. Then we have CD4 receptor inhibitor like 355, which are under clinical trials and investigation. So all these drugs are under pipeline, which may come into the market in the near future, which are add-ons or which are may become the mainstay in the management of as antiretroviral therapy and may be included in the heart regimen. So before I conclude this lecture of antiretroviral drugs, I would like to recap with this particular HIV life cycle and antiretroviral drug targets. Please remember this diagram, which depicts the replication of virus right from the infection, attachment, entry, fusion, emptying of the contents to the transcription procedure and integration into the human genome, to the transcription and translation, and also the synthesis of proteins, viral proteins, budding of the virus, and then the development of daughter virions, and these daughter virions which are ready even to attack the fresh and new cells, host cells. So I already told you that there are 6 categories of drugs available. So reverse transcriptase inhibitors are NNRTIs and NRTIs and NTRIs, that is nucleoside and nucleotide reverse transcriptase inhibitors and non-nucleotide reverse transcriptase inhibitors. They act by the inhibiting the enzyme reverse transcriptase. Then we have the next category of drugs, that is the protease inhibitors. The protease inhibitors, they inhibit the protease enzyme and they they inhibit the late stage in the retroviral replication. Then we have the 4th one, which is the entry inhibitors like maraviroc, which are going to block the CCR5 receptor antagonist, which are binding to the host cell wall. Then we have the fusion inhibitors like enfuviritide, which is going to block the fusion of the virus to the cell wall and emptying into the genetic material into the host cell. Then lastly, we have the integrase inhibitors. So these integrase inhibitors, they block the enzyme integrase, and the drugs which are used as entry inhibitors are integrase inhibitors are raltegravir, elbitagravir, dolutegravir. So with this particular diagram, I think it will be very clear to understand the mechanism of action of various drugs which are going to act at various levels of the replication of the retrovirus. And with this, I conclude my talk, and the next session of the antiretroviral drugs will follow. Thank you so much. Good day.